Welcome to the deep dive. This session is really tailored for you, focusing on understanding blood flow like the top professionals.
That's right. Our mission today is to unpack these sources covering skeletal muscle blood flow during exercise, and then the heart's own supply, the coronary circulation.
We're aiming to go deep, really extract the core insights from this material you've shared. Normal function, exercise adaptations, ischemic heart disease.
Exactly, but strictly based on the text provided. No skimming the surface here. We want you to master this.
Okay, let's dive in. Skeletal muscle first. The sources immediately flag it as, well, a huge part of body mass.
And when it works, it needs a massive amount of blood. Just enormous.
The numbers are striking. Resting flow is pretty low, what, 3 to 4 milliliter per minute per 100 grams?
Yeah, relatively low, but then exercise hits, and things change dramatically.
Dramatically is right. The source has a 25 to 50-fold increase, up to maybe 100, even 200 milliliter in 100 grams. That's staggering.
And it doesn't stop there. For elite endurance athletes, we're talking peak flows possibly hitting 400 millimillimeter in 100 grams in those trained muscles.
400. Okay, so the big question is, how does the body possibly manage that kind of increase?
Well, part of it is how the flow works during contractions. Figure 21:1 in the source material shows this rhythmic pattern. Flow actually goes up between contractions.
When the muscle relaxes.
Right. But then it drops quite sharply sometimes during the contraction itself.
Why that dip? Is it just squeezing the pipes?
Essentially, yes, it's mechanical compression. The muscle fibers contract and physically squeeze the blood vessels running through them.
So a really strong, sustained contraction could almost cut off its own supply.
It can, yeah. A strong tetanic contraction, the source says, can nearly stop blood flow momentarily. Though it also notes that this rapidly weakens the contraction itself. You can't sustain that.
Makes sense. Okay, another key adaptation mentioned is at the capillary level. What happens there during exercise?
This is crucial for delivery. At rest, a lot of muscle capillaries aren't even open or have minimal flow.
Right.
But during exercise, the sources say pretty much all of them open up.
And that achieves what exactly? Two main things.
Two big benefits, yes. First, it drastically cuts down the distance oxygen and nutrients have to travel from the blood to the muscle fiber, much shorter trip.
Effective delivery.
And second, it increases the total capillary surface area available for that exchange by 2 to 3 times. Just much more interface for diffusion.
Okay, massive flow increase, dynamic changes during contraction, capillary recruitment. Now, how is this all controlled? The source really emphasizes local control.
Yes, this is fundamental. Local control means the muscle tissue itself is the primary regulator, responding directly to its own metabolic needs. It's self-regulation at the tissue level.
And the main signal driving that, lack of oxygen.
Decreased oxygen is presented as a primary driver, definitely. Active muscles chew through oxygen, levels drop in the tissue, and that directly triggers the arterioles, the small arteries, to vasodilate, to relax and open up.
But it's not just the direct effect of low oxygen, right? The muscle cells release stuff too.
Yeah, correct. Low oxygen also stimulates the muscle cells to release vasodilator substances, chemicals that signal the vessels to relax.
And the source lists a few suspects. Adenosine comes up as potent.
Adenosine is highlighted, yes. It's known to be a powerful vasodilator. But the text adds a bit of nuance, especially for skeletal muscle during exercise.
What's the nuance?
Well, the source mentions studies suggesting that while adenosine is involved, its effects might not last long enough or be strong enough to explain the entire massive, sustained increase in blood flow during prolonged, heavy exercise.
So it might kick things off, but other factors keep it going.
That seems to be the implication, like maybe the vessels become less sensitive to adenosine over time or other signals just become more important. It's a complex local mix.
And the text mentions other candidates in that mix. Potassium ions, ATP.
Yes, potassium ions, ATP itself, lactic acid, carbon dioxide, all listed as potential vasodilators released by active muscle.
But it sounds like the exact contribution of each one isn't fully nailed down.
The source is quite clear on that the precise quantitative role of each substance in the overall response is still, a bit uncertain, which tells you something about the complexity we're dealing with.
Absolutely. Okay, so local metabolic control is king, but there's also nervous system input, right? Sympathetic nerves.
Yes, the sympathetic nervous system plays a role. There are sympathetic vasoconstrictor nerves that release norepinephrine.
And they can clamp down on flow.
Quite significantly, yeah. Maximal activation can cut resting muscle blood flow by half, maybe even 2/3.
But local control overrides this during exercise.
Mostly, yes. But that sympathetic tone is important in other situations. Like the source mentions maintaining blood pressure during shock or stress, shunting blood away from muscles when needed systemically.
And then there's the adrenal medulla, pumping hormones into the blood during exercise. Norepinephrine and epinephrine.
Right, circulating hormones add another layer. The circulating norepinephrine generally constricts vessels via alpha receptors, similar to the nerves.
But epinephrine is different.
Epinephrine often causes a slight dilation in muscle vessels. It tends to activate beta-adrenergic receptors more, and those cause vasodilation. So you get this interplay between alpha constriction and beta dilation effects from the circulating hormones.
Wow. Okay. Local metabolic signals, mechanical compression, nerve signals, circulating hormones. Quite a system just for the muscles. Let's zoom out now. How does the whole circulatory system readjust during exercise? The source points to three big essential effects.
These are the cornerstones of the systemic response. 1, massive sympathetic nervous system activation. 2, an increase in arterial blood pressure. And 3, a huge increase in cardiac output.
Let's take that sympathetic activation first. Signals from the brain flood the control centers.
Exactly. The brain signals the vasomotor center, leading to widespread sympathetic discharge throughout the body. At the same time, parasympathetic signals to the heart are reduced or attenuated. It's a double whammy.
What does that do to the heart specifically?
Big effects. Heart rate shoots up potentially to 170, 190 beats per minute, and pumping strength can basically double. This is from both the direct sympathetic stimulation and taking the parasympathetic brake off.
And the source says this is vital for boosting cardiac output beyond its normal limits.
Critically important. It pushes the heart beyond the plateau of its normal function curve. Without that sympathetic drive, cardiac output would hit a ceiling much sooner.
Okay, heart effects. What about the arterioles elsewhere in the body?
Widespread constriction. The sympathetic system clamps down on arterioles in most tissues except the active muscles.
Why the exception for active muscles?
Because there, the powerful local vasodilator mechanisms we just discussed override the sympathetic constriction. So blood gets shunted away from inactive areas towards the working muscles.
And the source quantifies that shunt.
Yeah, it suggests this redirection can contribute up to maybe 2 liters per minute of extra flow specifically to the muscles. It's like borrowing blood from elsewhere.
And thankfully, the heart and brain are mostly spared this constriction.
Yes, the source calls that fortunate. Their vessels don't have strong vasoconstrictor innervation compared to other areas.
Okay, third sympathetic effect. Veins and capacitance vessels.
This is a really key point. The sympathetic system causes powerful contraction of the walls of veins and other large vessels that hold blood volume.
And this increases mean systemic filling pressure. What does that mean practically?
It means the pressure driving blood back towards the heart increases significantly. Think of it as squeezing the reservoir to push more blood towards the pump. The source says this is one of the most important factors enabling the heart to increase its output.
How much can it increase?
The text gives numbers like going from a normal 7 mmHg up to maybe 30 mmHg during maximal exercise. Even just tensing abdominal and skeletal muscles contributes by compressing internal vessels. It all helps push blood back to the heart.
That's a huge pressure increase on the venous side. Okay, second major effect, the rise in arterial pressure.
This follows directly from the sympathetic actions we discussed, the vasoconstriction in non-active tissues, the boosted heart pumping, and that increased mean systemic filling pressure all contribute. Arterial pressure almost always goes up during exercise.
Typically by how much?
Usually 20 to 80 mmHg according to the source, but there's an interesting nuance depending on the type of exercise.
Ah, right. Localized versus whole body.
Exactly. If you're doing intense exercise with just a few muscle groups, like, say, weightlifting, the sympathetic drive is strong, but the overall vasodilation isn't massive. So pressure can spike quite high, maybe 170 mmHg or more.
But with something like running.
With massive whole body exercise, even though sympathetic output is high, you have extensive vasodilation across huge muscle beds. This vasodilation counteracts the pressure-raising effects, so the rise might be more modest, maybe just 20 to 40 mmHg, despite the enormous cardiac output.
Interesting. And you mentioned earlier this pressure rise is critical for getting that massive flow increase into the muscles. It's not just about the local vasodilation.
Yes, the source makes a really compelling point here. It cites lab experiments where muscle flow only increased about 8-fold if you prevent arterial pressure from rising.
Only 8-fold. But we know athletes can achieve much more.
Way more. More than 20 times the normal total body flow in a marathon runner. The difference is that pressure increase. A, say, 30% rise in arterial pressure provides more driving force, and it actually stretches the vessel walls a bit. Combine that higher pressure head with the local vasodilation, and that's how you get those truly huge 20-plus fold increases in muscle blood flow.
That's a fantastic insight, pressure and dilation working together. Okay, and the third essential effect ties it all together, the increase in cardiac output.
Absolutely fundamental. The source essentially says your ability to increase cardiac output is just as important as muscle strength itself in limiting how long you can sustain exercise.
The marathon runner example again.
Perfect example. Their performance limit is heavily tied to how much oxygen their heart can deliver via increased cardiac output.
The source uses figure 21-2, a graphic analysis, to show how this cardiac output increase happens, moving from rest, point A, to heavy exercise, point B.
Yeah, this graph is really helpful for visualizing the system dynamics. The cardiac output curve itself shifts upward dramatically.
And that shift is almost entirely due to
Sympathetic stimulation of the heart, that increased rate and strength we talked about. Without it, the source estimates CO could maybe only increase 2.5-fold, hitting the normal heart curve's plateau. Nowhere near the 4 to 7-fold increase seen in athletes.
But for CO to actually increase, venous return has to increase too. The graph shows changes to the venous return curve as well.
Critically important changes. If the venous return curve didn't change, CO would be stuck at that normal plateau, no matter how hard the heart was stimulated.
So what changes on the venous return side?
Two main things. First, that increase in mean systemic filling pressure we discussed from venous constriction and muscle tensing. This higher pressure shifts the entire venous return curve to the right on the graph,
Pushing more blood towards the heart at any given atrial pressure. What's the second change?
the slope of the curve gets steeper. It rotates upward. This happens because the resistance to blood flow back to the heart decreases.
Why does resistance decrease?
Because of the widespread vasodilation in all those active muscles, lower resistance in such a large part of the circulation makes it easier for blood to flow back, increasing venous return, hence the steeper slope.
So higher starting pressure shifts it right, lower resistance steepens it upward.
Exactly, and the combination dramatically lifts the whole venous return curve. The new intersection point, point B, shows that huge increase in cardiac output.
And interestingly, the right atrial pressure itself might not change much.
Often very little change, or it might even fall slightly with a really strong heart response, as the source notes, which contrasts with a weakened heart, where that pressure would likely rise significantly because the heart struggles to keep up with the increased return.
That figure really pulls it all together nicely. Okay, let's pivot from the exercising body to the heart's own supply system, the coronary circulation. The source immediately stresses its importance.
Immense clinical significance. Coronary artery disease is linked to about 1/3 of all deaths in Western countries, the text says. And most older adults have some level of impairment. Understanding the basics is vital.
Let's start with the anatomy, referencing figures 21-3 and 21-5.
Yeah.
Main arteries run on the surface.
That's right. The main left and right coronary arteries are epicardial on the surface. From these, smaller intramuscular arteries branch off and dive deep into the heart muscle itself.
And there's a specific network mentioned just under the inner lining.
Yes, the subendocardial arterial plexus. It's right beneath the endocardium. This is crucial because the source states very clearly, the heart muscle gets its nutrition almost entirely from these coronary vessels. That innermost layer, maybe 0.1 millimeter thick, gets very little directly from the blood inside the chambers.
Where do the main arteries typically supply? Left coronary.
Primarily the anterior and left lateral portions of the left ventricle.
Or the right coronary.
Usually most of the right ventricle, and importantly, in about 80–90% of people, it also supplies the posterior part of the left ventricle.
After nourishing the muscle, where does the coronary blood drain?
Most of it, especially from the left ventricle, about 75% of the total coronary flow collects in the large coronary sinus, which empties directly into the right atrium.
And the rest?
Blood from the right ventricle mainly drains via smaller anterior cardiac veins, which also empty into the right atrium. And then there are tiny Thebesian veins that drain a minuscule amount directly into all 4 heart chambers.
What's the normal flow rate?
Resting flow is about 70 milliliters per minute per 100 grams of heart weight, which works out to around 225 milliliters per minute total for the average heart. That's about 4 for 5% of the total cardiac output at rest.
And during exercise, how much does it increase?
It increases significantly, of about 3 to 4-fold during strenuous exercise. Interestingly, the source notes the heart's workload can increase much more, maybe 6 to 9-fold.
So flow increases less than workload. How does that work?
The heart becomes more efficient. It extracts more oxygen from each unit of blood, compensating for the proportionally smaller flow increase.
A really unique feature of coronary flow, especially in the left ventricle, is its phasic nature. Figure 21-4 shows this. Flow isn't constant through the cycle.
Not at all. This is a key distinction. In the left ventricle, coronary blood flow actually drops to a very low level during systole, the contraction phase.
Drops during contraction. Why? Same reason as skeletal muscle.
Exactly the same principle, mechanical compression. The powerful squeeze of the left ventricle during systole compresses those intramuscular vessels intensely, impeding flow.
So the heart muscle mainly gets its blood supply during diastole, when it's relaxing.
Precisely. When the muscle relaxes in diastole, the compression is gone, and blood flows rapidly through the coronary arteries. This makes the duration of diastole really critical for heart muscle perfusion.
Especially at high heart rates, when diastole gets shorter.
Yes, that becomes a limiting factor. The right ventricle also shows phasic changes, but they're much less dramatic because it doesn't contract nearly as forcefully as the left.
The source also differentiates flow between the outer epicardial and inner subendocardial layers, referencing figure 21-5 again.
Right. Those subendocardial vessels, being deeper in the muscle, experience the most intense compression during systole. So flow to that inner layer is significantly reduced compared to the outer layers during contraction.
Does it compensate somehow?
The subendocardial arterial plexus helps, but this layer is inherently more vulnerable to ischemia, as the source points out. It's often the first to suffer when coronary flow is limited.
Okay, let's talk control. Similar to skeletal muscle, local metabolism is the primary controller.
Paramount for the heart. Increased heart activity means increased metabolism, and coronary flow increases almost directly in proportion to meet that metabolic need.
And the key metabolic signal is, again, oxygen demand.
Absolutely critical. The source states coronary flow is regulated almost exactly in proportion to the heart muscle's oxygen consumption.
Why is it so tightly linked?
Because the heart is incredibly good at extracting oxygen. At rest, it pulls about 70% of the oxygen out of the blood passing through. There's very little reserve left in the venous blood coming out.
So if it needs more O2, it had to increase flow. There's no reserve to tap into.
Exactly. Increasing blood flow is essentially the only way to deliver significantly more oxygen to the working heart muscle.
And the mechanism linking oxygen need to flow involves vasodilators again, like adenosine.
Yes, decreased oxygen in the heart tissue triggers the release of vasodilators. Adenosine is again presented as a key mediator. When oxygen is low, ATP breaks down, eventually forming adenosine.
And that adenosine leaks out and relaxes the vessels.
It diffuses out of the muscle cells and acts on the nearby coronary arterioles, causing them to dilate, increasing flow. It's a protective mechanism.
But there's a downside to losing adenosine during severe ischemia.
A major downside, emphasized in the text. While adenosine helps temporarily, if the ischemia is severe and prolonged, say, 30 minutes or more, the cell can lose a significant amount of the underlying adenine-based molecule.
And that's hard to replace.
Incredibly slow. The source says replacement occurs at only about 2% per hour. This loss of the building blocks for ATP is considered a major contributor to cell death during prolonged ischemic events. It's a crucial metabolic insight.
Are other vasodilators involved besides adenosine?
Yes, the source mentions others similar to skeletal muscle: potassium ions, hydrogen ions, acidity, CO2, prostaglandins, nitric oxide. It suggests it's likely a combination of factors, not just adenosine.
What about nervous control of coronary flow? Indirect effects are more important.
Yes, the indirect effects, mediated through changes in heart activity and metabolism, are generally considered dominant.
So sympathetic stimulation increases heart rate and strength,
which increases metabolism and oxygen demand. And that triggers local metabolic vasodilation. So the flow increases mainly because the heart is working harder, not primarily due to direct nerve action on the vessels.
and vagal parasympathetic stimulation.
That slows the heart and slightly decreases contractility. Less work means less metabolic demand, which leads to a slight indirect constriction via those same local metabolic mechanisms.
But there are direct effects of nerves on the vessels themselves.
There are. Parasympathetic nerves release acetylcholine, which has a direct dilator effect, though the source notes ventricular innervation isn't very extensive.
And sympathetic nerves, direct effects.
They release norepinephrine and epinephrine, which can act on both alpha constrictor and beta dilator receptors on the coronary vessels. Epicardial surface vessels tend to have more alphas, intramuscular more betas.
So the net direct effect is usually
Often a slight overall constriction from the sympathetic nerves directly, but the source adds a really important clinical point. Sometimes those alpha constrictor effects can be excessive.
leading to problems even without blocked arteries.
Yes, it can cause vasospastic ischemia, where the artery spasms shut due to nervous signals, potentially causing angina pain. But again, under normal circumstances, the powerful local metabolic control usually overrides these direct nervous effects very quickly.
Good point. Let's touch on cardiac muscle metabolism specifically. Anything unique compared to other tissues?
One key difference highlighted is the primary fuel source at rest, fatty acids. The source says they account for about 70% of the energy.
What about under stress, like low oxygen?
Under anaerobic or ischemic conditions, the heart relies heavily on anaerobic glycolysis, breaking down glucose without oxygen. This produces a lot of lactic acid.
And that lactic acid might be related to cardiac pain.
The source suggests it's a likely contributor, yes. The buildup of acidic substances when flow is poor could irritate pain receptors.
And ATP production is mostly aerobic.
Overwhelmingly, more than 95% comes from oxidative processes in the mitochondria. But as we discussed, when ischemia hits hard, ATP breaks down to ADP, AMP, and finally adenosine.
Which leaks out, helps dilate vessels, but risks depleting the cell's building blocks.
Exactly that double-edged sword. Lose too much adenine base for too long, and recovery becomes very difficult, likely contributing to cell death. That slow replacement rate, 2% per hour, is a critical bottleneck.
That metabolic vulnerability really sets the stage for understanding ischemic heart disease. The source calls it the most common cause of death in the West. Focus is on acute events.
And the underlying cause in almost all cases is atherosclerosis.
Can you walk us through the source's description of atherosclerosis?
Sure. It starts with cholesterol depositing beneath the endothelium, the inner artery lining. This triggers inflammation, fibrous tissue growth, and often calcification. The result is an atherosclerotic plaque.
Which narrows the artery.
Right. It protrudes into the vessel lumen, obstructing blood flow. Factors like genetics, diet, sedentary lifestyle, high blood pressure, smoking, they all predispose to this. And the source notes a common location is near the origin of the main coronary arteries.
So what causes an acute blockage? A sudden event.
The source says this almost always happens where there's a pre-existing atherosclerosis. Two main triggers. First, thrombus formation, a blood clot.
How does that form?
Usually, the surface of the plaque cracks or ruptures. This exposes underlying material, triggering platelet aggregation and clot formation, fibrin, trap cells, right on the plaque, potentially blocking the artery completely. A piece might break off as an embolus too.
And the second trigger?
Local muscular spasm of the artery wall, may be initiated by irritation from the plaque itself or nervous reflexes. This spasm could block flow directly or maybe lead to injury that then triggers clot formation.
Thankfully, the body has a backup system, mentioned prominently, collateral circulation. Figure 21-6 is referenced.
Yes, this is potentially life-saving. Normally, there aren't large direct connections between major coronary branches, but there are lots of tiny pre-existing anastomoses, small vessels linking them, maybe 20 to 250 micrometers wide.
How do they help in a sudden blockage?
They start to dilate almost immediately, within seconds, but the source is clear. Initially, the flow through them is usually way too low, less than half what's needed to keep the muscle alive. They don't enlarge significantly for the first day or so.
But they grow over time.
Crucially, yes. Over the next few days, they enlarge. Flow doubles by day 2 or 3. And the source suggests that within about a month, these collaterals can often develop enough to provide near-normal resting blood flow to the area.
So that explains why people can recover if the initial damage isn't too vast.
Exactly. That time allows the natural bypass channels to develop.
What if the atherosclerosis develops very slowly, over years?
Then the collaterals can develop alongside the blockage. So as the main vessel narrows gradually, the collateral pathways enlarge progressively. This can prevent any sudden acute event. The person might have adequate flow at rest for a long time.
But eventually, even that might not be enough.
Right. The atherosclerosis might outpace collateral growth, or the collaterals themselves might become diseased. This leads to chronic ischemia and eventual heart failure symptoms.
Which brings us to myocardial infarction MI, a heart attack. defined as.
The area of heart muscle that dies because its blood supply is cut off or critically reduced beyond the point of survival.
What happens immediately after the blockage?
Flow stops except for any minimal collateral contribution. The area fills with stagnant, deoxygenated blood. The source describes it looking bluish-brown with engorged vessels.
And then over the next few hours?
Cells swell, vessel walls become leaky, causing edema, and within hours, if blood supply is near zero, the muscle cells start to die irreversibly.
Is there a threshold for survival?
The source gives one. Cardiac muscle needs about 1.3 milliliters of oxygen per 100 grams per minute just to stay alive. Normal resting flow provides about 8 milliliters. Even just 15–30% of normal resting flow via collaterals might be enough to prevent cell death in the surrounding zones. But the central core, with little or no flow, dies.
And we talked about the subendocardial layer being most vulnerable.
Yes. Due to that high systolic compression and high oxygen demand, damage often starts there and spreads outward. Subendocardial infarcts are common, even without full thickness damage.
A grim picture. The source details the main reasons people die after an acute MI. 4 main causes listed. First is decreased cardiac output, leading to shock.
Right. If a large part of the ventricle is damaged, the heart simply can't pump effectively. This is often worsened by something called systolic stretch, shown in figure 21-7.
Systolic stretch.
Yeah.
The damaged area bulges outward.
Exactly. Instead of contracting, the dead or non-functional ischemic muscle gets pushed outward by the pressure from the healthy contracting muscle. This wastes a huge amount of pumping force.
And if enough muscle is affected,
If more than about 40% of the left ventricle is infarcted, the source says cardiac shock or cardiogenic shock often develops. The heart failure is so severe, blood pressure plummets, and mortality is very high, over 70%.
second cause, damming of blood and pulmonary edema.
If the left heart can't pump blood forward, it backs up into the left atrium, then the lungs. Increased pressure in the lung capillaries forces fluid out into the air sacs pulmonary edema.
And this might be delayed, linked to kidneys.
Often, yes. The initial low cardiac output reduces kidney function. The body retains salt and water, increasing total blood volume over days. This extra volume further increases the backup pressure in the lungs. So someone might seem okay initially, then suddenly develop life-threatening pulmonary edema a few days later.
Third major cause, ventricular fibrillation,
Yeah.
VFib.
A huge cause of sudden death post-MI. Very common with large infarcts, but can happen even with smaller ones. The source highlights 2 particularly dangerous periods. The first 10 minutes after the MI, and then again starting about an hour later and lasting for a few hours.
Why is the heart so prone to fibrillate then? 4 factors mentioned.
Okay, first, rapid loss of potassium from the damaged muscle cells. This increases potassium levels outside the cells, making the heart muscle electrically unstable and irritable. An injury current. Ischemic muscle doesn't repolarize properly after contracting. It stays electrically negative on the outside compared to healthy muscle. This creates a constant electrical current flowing between injured and normal areas, which can trigger abnormal beats and fibrillation.
Third factor.
Powerful sympathetic reflexes. The body senses the low blood pressure from the failing heart and ramps up sympathetic activity. This further increases the irritability of the heart muscle itself.
And fourth,
Cardiac weakness and dilation. The damaged, stretched heart muscle increases the distance electrical signals have to travel. It can also create abnormal conduction pathways around the scar tissue. Both of these make circus movements, or re-entry more likely. That's where an electrical impulse gets trapped in a loop, re-exciting muscle over and over, leading to the chaos of fibrillation.
that combination of electrical, chemical, and structural changes makes VFib a major threat. The fourth cause of death listed is rupture of the heart wall.
Less common, but lethal. The risk increases a few days after the MI as the dead muscle tissue degenerates and weakens. The wall thins, systolic stretch worsens, and eventually it can just tear open.
Can doctors see this risk developing?
The source mentions imaging like echocardiography can track worsening systolic stretch, which is a warning sign for potential rupture.
If it ruptures.
Blood floods into the pericardial sac around the heart. This leads to cardiac tamponade. The heart gets squeezed from the outside, preventing blood from entering, causing a sudden collapse of cardiac output and death.
Sobering outcomes.
Yeah.
But people do recover. The source outlines the stages of recovery, referencing figure 21-8.
Yes. If the ischemia was very small, maybe no cells die, just temporary dysfunction.
But for a larger MI,
It's a process. Central core fibers die quickly, 1–3 hours. The dead zone might enlarge over days as marginal, severely injured cells give up. but surrounding areas that were just non-functional can recover as collaterals improve over days to weeks.
And the dead tissue gets replaced.
Yes. Fibrous tissue, basically scar tissue, grows in. Ischemia stimulates the fibroblast cells that make it. Over months to a year, this scar contracts and shrinks.
And the remaining healthy muscle compensates.
Right. The normal parts of the heart undergo hypertrophy. They get bigger and stronger to try and make up for the lost pumping function. So recovery can range from near normal function to permanently impaired, depending on the initial size of the infarct.
This recovery process highlights why rest is so important in treatment.
Absolutely critical. The source explains it's not just about reducing oxygen demand, though that's part of it. It's also about avoiding coronary steal syndrome.
Coronary steal, what's that exactly?
During increased heart activity, the blood vessels in the healthy parts of the heart muscle dilate strongly, but the collateral vessels supplying the ischemic area are often already maximally dilated or can't dilate as much.
So the healthy muscle steals the blood.
Pretty much. The increased flow preferentially goes to the healthy, widely dilated areas, effectively diverting blood away from the struggling ischemic zone, making the ischemia there worse, and potentially increasing the amount of muscle that dies.
So rest minimizes workload and prevents this steal phenomenon.
Exactly. It gives the ischemic area the best chance to survive on limited collateral flow.
After recovery, what's heart function like?
It varies. Could be near normal or significantly reduced pumping ability. But the source introduces the concept of cardiac reserve to explain functionality.
Reserve capacity.
Yeah, a healthy heart can pump maybe 300, 400% more blood than needed at rest. That's the reserve.
So even after an MI, there might still be some reserve left.
Often, yes. Maybe the reserve is reduced to, say, 100%. That person can likely handle normal daily life fine because resting needs are met and there's enough reserve for light activity. But strenuous exercise would push them beyond that reduced limit and overload the heart.
Okay, nearly there. Let's talk about pain. Why does ischemia hurt? You don't normally feel your heart.
The leading theory in the source is that ischemia leads to a buildup of pain-causing substances. Things like lactic acid, making the tissue acidic, or other inflammatory mediators like histamine or kinins.
And they build up because?
Because the blood flow is too slow to wash them away effectively. High concentrations stimulate pain nerve endings within the heart muscle.
And this is the pain of angina pectoris.
Correct. Angina is that characteristic chest pain occurring when the heart's workload temporarily outstrips its blood supply, usually due to underlying atherosclerosis.
Where is it felt? Just the chest.
Often beneath the sternum, but it classically refers pain elsewhere, commonly the left arm, shoulder, sometimes neck, jaw, or back. The source links this to shared nerve pathways in the spinal cord from embryonic development.
What brings on an angina attack?
Anything increasing heart workload. Exercise, strong emotions, also things that might slightly constrict coronaries, like exposure to cold. Even a large meal can increase workload enough to trigger it.
How long does it last?
Usually just a few minutes, relieved by rest. But it can be constant in very severe cases. The description is often pressing, squeezing, heavy, or burning. It makes people stop what they're doing.
Finally, treatment strategies mentioned in the sources. Drugs first.
For acute attacks, fast-acting vasodilators like nitroglycerin are key. For long-term management, drugs like ACE inhibitors, ARBs, calcium channel blockers, and ranolazine are mentioned.
And beta blockers like propranolol. How do they fit in?
Their main benefit, as explained, is blocking the effects of sympathetic stimulation on the heart. They prevent the heart rate and contractility from increasing excessively during stress or exercise.
So they reduce oxygen demand.
Exactly. By keeping the workload lower during potential trigger situations, they reduce the frequency and severity of angina attacks.
What about surgical treatments? Bypass surgery.
CABG.
Aortic coronary bypass grafting, used for significant blockages. Surgeons take a vein or artery from elsewhere, leg, arm, chest wall, and graft it onto the aorta and then onto the coronary artery past the blockage, creating a detour.
The source says it relieves pain well in most and can restore normal life expectancy if the heart muscle isn't already badly damaged. Less value if significant damage has already occurred.
And angioplasty.
The balloon procedure.
Used to open partially blocked arteries. A catheter with a balloon is guided to the narrowing. The balloon is inflated, squashing the plaque and stretching the artery open.
Results.
Often increases flow significantly, maybe 3-4-fold, providing relief for years in many patients, though the source notes a fair number eventually need bypass later.
Stents are usually placed during angioplasty now.
Yes, small mesh tubes deployed to prop the artery open and prevent it collapsing again. Restenosis. The artery lining grows over the stent.
Does restenosis still happen?
It can, yeah. in maybe 25–40% of cases within months, often due to scar tissue growing inside the stent. Drug-eluting stents, which release medication, have helped reduce this problem significantly.
And newer techniques like laser angioplasty are mentioned briefly, too.
Just indicating ongoing development in the field, we've covered a huge amount of ground, from the incredible physiology of muscle blood flow during peak exertion through the whole body's coordinated response, right down to the heart's own vital, intricate coronary system.
And delving into what happens when that coronary supply fails the metabolism, the consequences of ischemia and infarction, and the strategies for intervention and recovery. It really emphasizes the body's adaptability, but also its vulnerabilities.
Absolutely. Thinking about these details, the sheer scale of flow increase, the heart literally squeezing its own lifeline shut during systole, the critical metabolic bottleneck of adenosine loss, the body building its own bypasses with collaterals. It really gives you a much deeper appreciation for what's happening physiologically, doesn't it? Helps understand things on that professional level we aimed for.
It does. It moves beyond just names and labels to understanding the mechanisms and their implications.
So, reflecting on all this detailed information from the sources, what's one thing that particularly stands out or surprised you about the heart's intricate supply system or its response to stress?
For me, I think it's the stark reality of that metabolic limit, the slow replacement of adenine base after severe ischemia being such a hard constraint on recovery. And tying that to the practical importance of rest to avoid coronary steal, it connects the deep biochemistry directly to patient care.
That's a great point. Seeing those connections is key to mastering this. It helps us understand not just what happens, but why it happens.
Precisely. Seeing the whole system in action.
Well, with that, we've reached the end of this deep dive based on your source material.